Hi, my name's Mahmood. I'm a professor of ENT surgery in Brighton in the UK and also a professor of sustainable healthcare. I've had an interest for many years in medical supply chains, both the issues with our throwaway economy in healthcare and the potential solutions to try and stop this. My work actually has been in this area for nearly 20 years. So back in 2006, I actually uncovered labor rights issues in supply chains, which I'll come on to talk to you about, but also back then was obviously aware of the potential environmental destruction from our linear economy. And I've been working with colleagues around the world, including Sweden and Norway, for many, many years. And really, last year, I chaired a national report into green surgery. So you are welcome to look at that, which outlines what we can do within surgery in terms of reducing our environmental footprint, not just for our supply chains and our products, but also in terms of the care pathways and public health approaches. But I'm going to concentrate here really talking about the medical supply chains. And I'm sure those of us who work in healthcare see the vast quantities of goods that we use and we dispose of every day. So to put it in context, I have some data from England. The NHS, the National Health Service in England, disposes of 240,000 metric tons every year of clinical waste, the vast majority of that from hospital, and it is dominated by linear consumption. Almost 3/4 of what we use is disposable. Now, of course, some things will need to be disposable for safety reasons, such as needles and intravenous cannulae, but there are many things that I think we dispose of that simply do not need to be disposed of. And I'm going to come on to talk to you about what the harms of doing so are and what underlies these issues. It was not always this way. So those of us who are a little bit older remember when much of what we used in healthcare was reusable. And indeed, if we look at the carbon footprint of, for example, different approaches to a hysterectomy, removal of the womb, these data from our systematic review show that if you take a more traditional approach, such as a vaginal approach or an abdominal approach, where we use traditional surgical instruments to remove the womb, the carbon footprint is much, much lower than if you take a more modern approach, laparoscopic keyhole surgery or robotic surgery. Now, actually, the major difference that seems to be between these is actually what's in the red there, which is the production, use, and disposal of single-use equipment. So as we move to more modern approaches, we've had an attitude that this must come with disposable, and that's simply not true. You can make perfectly good reusable laparoscopic instruments, and there is no reason that most of what is used in robotic surgery cannot be reusable. Of course, there are companies that would like us to dispose of things, and there are people as well who find it convenient to dispose of things rather than think about reusing. We have also undertaken some carbon footprint analysis of the most common operations that happen in the UK, which will be similar across the world. And there we found that of the products that were being used, the carbon footprint was 2/3 due to single-use products. So that single-use agenda is really what we've got to do if we're going to tackle the medical products that we're using. And to show you that it doesn't have to be this way, we don't have a lot of data, but we do have some data from low resource settings. So a cataract operation performed in the UK has been carbon footprint at around 180 kilograms of carbon dioxide. That is the equivalent of driving a car from, say, London to Edinburgh, a petrol car. That's just one operation. That is multiplied, of course, thousands of times, if not hundreds of thousands across the world, every single day. But a cataract operation, the same operation performed in India, has a 30-fold lower carbon footprint at only 6 kilograms of carbon dioxide. This centre that reported this used highly efficient systems with a throughput of patients. They reused almost all of their equipment, most of which was locally produced. And they reported lower rates of infection from their first several million operations than we report in the UK. So this is the highest standard of care, both in terms of financial cost, carbon cost, and quality of care. Now, when we're thinking about approaches, circular economy is what we're talking about, where we keep products, materials within the system. And let's simplify it to three main ideas, which is reduce, reuse, recycle. There is a lot of things that I think we don't need to use in healthcare. So if we don't use that in the first place, we're going to save 100% of the carbon footprint. Now, some people will try to argue that reuse has an associated carbon footprint because we may have to decontaminate and sterilize products, and that is true. But actually, the data from a systematic review show that reuse in healthcare, and taking account of the carbon of decontamination transportation, reduces carbon by typically 38 to 56%. There is no other strategy we can use in healthcare that will reduce the carbon by that much. So if you use a single-use product, I'd be surprised if there's anything you can do to reduce the carbon by that much. And then we all like to think about recycling, and it gives us a nice visual aid to, hey, we've done something great for the planet. But let's not be naive, because recycling, if performed optimally, typically recovers 3 to 4% of the carbon. And in healthcare, that is difficult because those products are often multi-component and may be contaminated. So we can recycle everything and our planet will die. The other problem, there are many problems, but one of the other problems with throwing things away is it engenders this global value change where we have free market economics. Things that are thrown away, we want to produce at the cheapest possible price, and often that means outsourcing to countries where the costs of production are lower. Here are some elbow supports coming off of a production line in Mexico, and they're going into 6 different boxes. The box on the right is a US brand, the box on the left is a local Mexican brand. It's exactly the same product. This has just been outsourced production to the lowest possible place and rebranded. And we see that for many, many other medical products. The problem we see with outsourcing is that there is a risk of labour abuse because labour protections are not always present in many of these countries. So we managed to get some data from our colleagues in Norway where we got data on several thousand items where the suppliers were contractually obliged to tell the purchaser where the products were made. Nevertheless, data were not provided for half of cases, but where they were provided, we have mapped that about half of all medical products are made in countries with a known high risk of labour abuse. And I'm going to come on to show you that's not just a theoretical risk, it's a real risk. So when we think about incentives and barriers, I think there are 3 things that lead to this linear economy. First of all is that perceived risk of infection. I'm going to come on to tell you that that's not always true. And in particular, I've invented a term called yellow washing, which is where you try to cover up the potential for risk of infection without true evidence. And that leads to overuse of materials and our throwaway economy. Economic drivers, we think it's actually cheaper to throw things away. And I'm going to show you again that that's simply not true most of the time. Most of the time, being green will save money. And then it's the human and physical resource for reuse. Historically and even today, we've got rid of a lot of the infrastructure we need to decontaminate and provide goods, and that makes it difficult to move to a circular economy. I'm going to show you examples of what has happened. So first of all, let's talk about PPE, personal protective equipment, which we saw obviously come to the fore during the pandemic, but we have history here. So back in the early 90s, there was this virus that everybody was scared about called HIV, which we were all going to die from. And there was the messaging on the left there in the UK about the potential risks here. We know that at that time, glove use went up in healthcare by a large amount, which doesn't make sense because this is not spread by skin contact. And then the most recent thing is the COVID-19 pandemic, where again, we saw glove use, but also gown use and mask use go up by huge amounts because this virus that was going to kill us. And it's true that it was scary, but this is a respiratory virus. It is not spread by skin-to-skin contact, and I have no idea why we were told to put on all this PPE, and the latest evidence suggests it made absolutely no difference to risk and may have increased the risk because people did not wash their hands adequately, because washing hands is actually better. So, this is not a new phenomenon, though, because glove use prior to the pandemic in the NHS in England is 1.7 billion every single year. That's enough. If you put those gloves end to end, that would almost stretch the moon. That's just the NHS in England. That's a hell of a lot of plastic. We calculated the carbon footprint of all of that PPE, and we found that the gloves alone, with the equivalent of driving a petrol car around the earth 8,300 times every single year. What we do know is that nearly 2/3 of glove use is inappropriate. People have become habituated to wearing gloves for no good reason because perhaps they do not understand why they're required. They're only required when there is potential contact with infected body fluids or broken skin because of the high bacterial load on those surfaces. That means you should reduce the risk of accumulating those bacteria on your hands. In all other circumstances, washing your hands is the safest thing. And the inappropriate use is perpetuated by individuals who copy this behaviour and by institutions who promote this idea that we need to wear gloves, for example, during the pandemic. But it actually puts patients at risk because it's more likely to spread infection because people forget to wash their hands and they touch all sorts of surfaces with gloved hands as if they magically stop infection. What we find is that Malaysia, which is the epicenter for production of gloves, 70% of the world's glove production, they are now creating a new oil refinery to help feed the synthetics, plastics, polymers that we are demanding for our gloves, importing hundreds of thousands of barrels of oil. But also what we know is that, unfortunately, in Malaysia, the glove manufacturer is not up to the standards that we would like. So there are over this is the largest manufacturer of gloves. It's called Top Glove. They have a compound of over 30 factories, and this is the shop floor where there are these workers. These workers are actually all migrant workers. And we've had some data where we surveyed 1,400 of these workers, and we found that nearly half of them had paid illegal recruitment fees for this golden opportunity to work. They've come from places such as Nepal and Bangladesh, where they are desperate for work. Some of them have sold land. They've typically paid $2,000 for this opportunity, sometimes up to $5,000. These are illegal recruitment fees. Historically, when they turned up, they would have their passports confiscated. They would work for up to 3 months without a single day off. They would pay for accommodation provided by the factory, and the working conditions were not good. On the left here is a factory manager talking to a worker at Top Glove, and on the right is another major supplier of gloves called Brightway, which probably has the worst accommodation you've seen, where the workers lived in shipping containers. So for 3 years, the entire existence of these people is to live in the shipping containers, to be transported to the factory, work 13 hours in temperatures up to 70 degrees Celsius, typically for at least 3 months without a day off. Mental health issues are serious, and sometimes there have been beatings of workers that will not comply. But people do not leave. They have these huge debts they must repay. And although I've shown you some examples, there is endemic abuse of migrant workers in Malaysia, not only in the glove industry, but other industries. But in the gloves industry, all of these suppliers have been found to have serious labour rights abuses. You can read our report into it. What else? Textiles. So unfortunately, in the UK and in many health systems around the world, the majority of drapes and gowns that are used in surgery are disposable. About 2/3 of them in England are single use. And again, this is often based upon misconceptions. So the British Orthopaedic Association has this statement that thin cotton drapes and gowns have no place in orthopaedic surgery. That is absolutely true, but cotton has not been used as a material for drapes and gowns in Europe for over 3 decades. So this is very misguided. In fact, all health textiles must be made of plastics according to European regulations, and throughout their life cycle, they must meet the standards for liquid penetration and microbial penetration. And if you use a reusable version, you can reuse that 55 to 75 times, meeting all standards, and has 1/3 of the carbon footprint. So no health system can say that they are trying to be sustainable whilst they continue to use single-use drapes and gowns. The standards, for example, in the UK, HCMO 104 are very clear on the microbiological profile. These are sterilized using steam sterilization, which is the same process that is used for surgical instruments. So it is absolutely safe, and there have never been any concerns, despite perhaps some misconceptions sometimes spread even by companies that will supply you with single-use drapes and gowns. The problem, for example, with single use is, of course, we want the lowest possible price. And during the pandemic, we found that some of our gowns were manufactured in the northeast of China using forced North Korean labor from over the border, where between 70 and 100% of the salary of these workers was sent to the North Korean state. Metal instruments. I find it bizarre that we think it's okay to throw away pieces of metal. In the NHS in England, 52 million of these are used. The vast majority are made in high-risk countries. So, for example, if you go into an accident emergency, a casualty in England, typically you will have a suture set that is disposable. We stitch things up and then we throw them away. The same in outpatient clinics. And the same for even things like removing sutures. This, again, is from historic scares. In the 1990s in the UK, we had inconsistent and inadequate sterilisation. People were using autoclaves, steam pressure cookers, effectively, in the back of their rooms, and they weren't necessarily always up to standard. And then we had this prion, this protein that was misfolded that potentially could cause serious harm, and perhaps we were all going to die. That hasn't happened, and there is just about 0 prion protein in the UK, if any. But what happened is, rather than deal with inconsistent or inadequate sterilisation, unfortunately, the UK got rid of a lot of its infrastructure for allowing metal instruments to be reused, and that world doesn't exist. Where we do have reusable instruments now, the standards are very high. HTMO 101 makes it clear that everything must be monitored, all processes must be verified. I have no concerns about the sterility of equipment, but we don't have the infrastructure, so we just think let's throw things away. 70% of all the world's surgical instruments are actually manufactured in Pakistan using what can only be described as sweatshop labor. These workers will work typically 12 to 13 hours a day, 7 days a week. They will get paid between $1 and $2. They work in these difficult environments with heat, with metal dust, with risk of serious injuries, sometimes minor, sometimes more serious, even arms being torn out where there is no compensation for these workers. Of the 50,000 workers, several thousand are children, some as young as 7, and I've seen 7-year-old children working on grinding machines to make these instruments that we just want to throw away. The typical age of starting in this industry is at the age of 12. These children do not go to school. 50% of them are literate. When we've interviewed and surveyed them, they tell us that they hate this work. They do not want to be working. They would like to go to school. They would like to play cricket in the street with their friends. I say that when we throw things away, we throw away money, we throw away our planet, and we also throw away human dignity when we fail to value everything that we are using. The economics of this. So to come on to the financial side, we have this bizarre ideas, certainly in many health systems, where we fragment our costs by place and time, risking some false accounting. So we are often asked to meet our budgets within a year, yet that makes it difficult to invest in what we know in the longer term will save money. We are also asked to just meet our budgets within our department. So for example, if you buy disposable drapes and gowns, it might look relatively cheap. But if you take account of the waste disposed, if you take account of the procurement structures that are required to support all of that, actually we know that it costs more. In fact, the NHS has looked at it and found that you're going to save at least half of the price by buying reusable if you actually do some correct accounting. And in that green surgery report that we produced last year, we looked at 142 case studies of green strategies in surgical care, and we found all of them save money, sometimes small, sometimes large. Now, it's not going to be the case that we will always save money by going green, but it is the case that in the vast majority of cases, by being green, we will save money. And if that won't drive things, I don't know what else will. But when we have these purchasing models as well that are based upon let's continue to buy things, there can be perverse incentives for suppliers to feed into that. Now, many suppliers are good, but some will have perverse incentives. So, for example, there's planned obsolescence where products are designed to eventually fail or be thrown away. Here's a drill, it's called System 7. System 7 apparently will soon not be supported any further by software or hardware. You must buy System 8. I can't tell the difference with System 8, but we will have to buy that. There's a electrosurgical dissector, which will cost typically $800, but it's single patient use. You use it once and then it is thrown away. There is no reason that this product cannot be made reusable. In fact, there is something called the Association of Medical Device Reprocessors who remanufactures these and certifies them as perfectly safe for use. They're used widely in the UK and across the US. And they're perfectly safe. What they have to do is change the actual pads at the end to make them reusable, which is quite a simple process to enact. But also inside here, there is a chip. That chip is actually programmed to only allow this product to be used once. It has to be removed and a new chip placed inside to allow this to be reused. It is sterilized, but eventually it fails because the plastic cannot stand the sterilization. If this product was designed from metal, designed with the appropriate chip, it could last hundreds of years. And instead, in the NHS in England, we use 48 million electrosurgical products that we throw away every year. You can also use regulation to say, hey, this product cannot be reused. Here's a pair of scissors, which would be ridiculous to reuse. So you label it to say, hey, this product is not certified for reuse, so you should throw it away because otherwise you'd be going against regulations. 5.9 million single-use scissors in the NHS in England. I find that disgusting, and I can tell you, of course, where those are made. So, we're working now towards policy and practice solutions that I think apply not only to the UK, but to countries, I hope, in other settings. First of all, We need to incentivize reuse through policy. So we have produced a policy brief recently which outlines the evidence for why reuse is the most important strategy for reducing the environmental footprint of the medical products that we use. And I'm glad to say that in the UK, this has now been quoted, and a Design for Life roadmap has been set out that says we will commit to reducing single-use products as much as possible. The detail has yet to be worked out, I would say. So what can that actually enact? So we need to align all our structures within policy and within process at national level to incentivize the reuse agenda. That includes, to my mind, preferentially purchasing reusable products embedded into national policy. We say we will always buy a reusable product where it's safe to do so. We need to look at the infrastructure to enable that to be developed. For example, our decontamination and sterilization facilities. For example, many countries do not have the sterilization facilities for reusable textiles and drapes, and that needs to be developed. We need to look at the regulation of medical devices so it is aligned to support reuse. You cannot actually say, oh, that cannot be reusable. You tell us why. And we need to explore other models of buying, such as servitization economics, where we buy a service, for example, for endoscopes, healthcare textiles, perhaps electrosurgical products. Rather than buying the product, we buy that service. You must supply that service. If you want to make lots and lots of products, it's going to cost the company, not us, because we will not be paying any more for that service. We all know from other contexts that decarbonizes health system and usually saves the purchaser quite a lot of money as well. We are trying to embed this also because policy at government level can take some time, but we are trying to show real world change through purchasing practice. So I've created a Circular Healthcare Economy Alliance. At the moment, that is 5 UK hospital trusts, but we are open to others from anywhere internationally to join us. What we have said is a simple statement that we will reduce single-use medical equipment and consumables, reusing wherever it is clinically feasible and appropriate to do so. And we are working through to see where we can maximize that opportunity. And we'll be estimating the carbon and financial savings. But I can tell you, we've only just started, and already my hospital is saving at least $250,000 every single year. To match that, I'm doing an evidence-based ranking of health providers by collecting evidence that already exists on where it is safe and environmentally preferable to reuse medical products, using academic papers and case studies, using that to then create a scoring system for hospitals and rank the hospitals on their environmental performance, because we cannot allow individual, unevidence-based practice because we simply do not have our time to do so. Our planet will not withstand that. So, I come to you with the idea that we need to move to a reuse economy because it will be better for us, it will be safe for our patients, and it will be definitely better for our planet. Thank you.